Dr. Ragini has done near about the 85,000 surgeries, and in that 40,000 surgeries she has done by SICS. So Dr. Ragini.
Thank you, Dr. Lani sir. Padma Shri Dr. Lani sir is my teacher. Respected Professor Dr. Kamaljeet Singh sir, a very senior professor and advocate of SICS, Professor Dr. Ruchi Goyal, Dr. Manilal sir, who is our friend, and everybody present here today in this lovely auditorium. I will be talking on the technique of Visco expression in SICS. The advantages of SICS are that it is a sclerocorneal self-sealing incision. There is a lesser learning curve when you are changing from ECC to SICS. It has been many years since the year 2000 that we have stopped doing ECC completely, and we are doing only manual small incision cataract surgery or phacoemulsification. Compared to phacoemulsification, it is a low-cost procedure. It is less machine dependent. It is not completely independent because you need a good microscope, you need a good bipolar cautery, but you do not need a phacoemulsification or an assistant to run the phaco machine. It is less damaging to the endothelium because the nucleus is delivered fast, and since you are using a viscoelastic, it keeps the corneal endothelium protected at all times. Now, what is important is, and what are the steps? The superior rectus bridle suture is extremely important in visco expression. There are various techniques, and as many people sitting here today, there may be that many techniques because one modifies and makes their own technique. But one thing is important is that in visco expression, the bridle suture is important because that helps to exert the pressure so that the nucleus can be delivered. The conjunctival flap is very, very important, like sir said, because it covers a hood and covers the wound, which keeps it safe, and also the patient does not feel anything. The second day, unless and until you pull the upper lid, you do not know by which technique the patient has been operated. It is essentially a sclerocorneal tunnel. I have seen many advocates of corneal tunnels, but it can be done only in very, very small cataracts because any corneal tunnel which is more than 3.2 will not be safe. Capsulorhexis is not a must. It can be done even with any sort of capsulotomy. Anterior chamber entry, hydro techniques, the nucleus rotation, the nucleus delivery, cortex aspiration, IOL implantation, and reposition of the flap. So these are the steps of the surgery, the visco expression surgery. So as you can see over here, it is very important to make a proper conjunctival flap and not keeping it at 12 o'clock, but keeping it at 10 o'clock or 2 o'clock ensures that it is covering the wound completely and it doesn't move. So this is a cautery and this is the flap reposition at the end of surgery, as you can see so clearly. So it is a very, very important step which should not be taken very lightly because this is what makes the patient comfortable and this is what makes the patient cosmetically better and safe with respect to infection. So this is a very, very important step. After that, as you can see over here, this is the conjunctival flap which is being made, the cautery, and now this is the incision. The incision is a modified frown incision because this is an incision which will be astigmatically safe. It can be made, the groove is made with a 11 number blade, and this is a tunnel which is being made. Now the set of tunnel blades are extremely reasonably priced in India, and hence every blade which is comfortable should be used. This is the capsulorhexis. I'm a left-handed surgeon. So as you can see, the hydro technique separates the nucleus and the epinucleus. It also separates the nucleus from the cortex and reduces the size of the nucleus. It makes the nucleus free. This is impaling the nucleus with the capsulotomy needle, rotating it and bringing it into the anterior chamber. Now this is very, very important before you can deliver it. Now pulling the superior rectus and the pressure on the tunnel with injecting viscoelastic brings the nucleus out, keeps the endothelium safe. This is the AC maintainer which we use, and the single port aspiration cannula, which is named the Lahne's cannula, which makes it very comfortable to do a 360-degree cortical wash completely. The IOL is then implanted under the BSS or the ringer lactate. It can be also done with viscoelastic. So these are the steps of the visco expression technique, as you can see over here. This is another case where you can see the conjunctival flap, the incision as it is made. So this is the incision. It is midway into the sclera and into the cornea. The length and the breadth should be made such that it has good geometrical symmetry, so that it is astigmatically neutral. Instead of the capsular rhexis, sometimes in a mature cataract an envelope also will do. These are the side ports with an MVR blade, and the incision, when it is extended, one has to cut when you go in. You can see the golden ring which is present after the hydrodissection, which indicates the end point. This step is extremely important, is rotating and bringing the nucleus anteriorly. You can see the superior rectus is being pulled and visco injected. It is very simple. You do not go into the anterior chamber. You are using the visco cannula and you are doing the surgery. The AC maintainer and the cannula help to remove 360 degrees of cortex and makes it even easy to clean the undersurface of the anterior capsule. The IOL is then implanted either by viscoelastic or, as in this case, under ringer, dialed into the bag. The ports are hydrated and the conjunctival flap is sealed. As you can see over here, the visco is removed. It's a very simple technique. It can be done very fast. It's very safe. As you can see, these are few videos which demonstrate the same technique, so it is easy. The tunnel is, as you can see, it is a modified funnel. There are scleral pockets which help the nucleus to be removed by making the external incision very small. When you make an entry, there is a dimple which shows that the corneal valve is correct. It was very difficult for me as a left-handed surgeon to do the rhexis, but I did learn eventually with Lahne sir's teachings. As you can see, it is cut when you go in, and the internal incision is really very big. So that is very good. This is after hydro, you have to coax the nucleus, rotate it, carousel it, and bring it into the anterior chamber. This is called as luxation, because this luxation helps you to deliver the nucleus. So there's 2-point delivery in visco expression, luxation, and then the external delivery is very, very important. Putting the IOL in the bag, cortex can be removed even after the IOL is placed inside. This is another case where even a brown cataract, as you can see, this patient has a very, very hard brown cataract. In this patient, we have used the dye to remove. Now, this is the rhexis, but this is a very, very hard cataract. And you can see the movement of the nucleus while doing the rhexis. In this case, if there is difficulty, instead of this needle, a Utratas forceps can also be used. Now, it would be very difficult to manage this case by phacoemulsification even in the best of hands, because it would take a long time and a large amount of ultrasonic energy to emulsify this nucleus. The fibers would be very leathery. But as you can see in this case, SICS makes it very easy, the staining of the capsule, and now the rhexis can be completed even after the extension, which makes it easy. The staining helps to see where the rhexis is, because there is such poor glow that otherwise this capsule would not be visible. A larger rhexis is done here, which one must remember when the nucleus is hard, that the rhexis should be large, because only if the rhexis is large. And now you put a lot of viscoelastic to protect, and then you stop the AC maintainer at this time, and the cataract is so easily removed. So easily removed. There is no stress. There is no stress to the surgeon at all. This step is extremely important. Rotating the nucleus, harpooning it with the needle, rotating it and bringing it into the anterior chamber. This is one step which remains to be done very thoroughly. Otherwise, there will be subluxation, there will be vitreous loss. And the rhexis, one must remember that in a visco expression or a SICS, the rhexis is little larger than what you do in phacoemulsification because you need to bring the nucleus out. This is again a case done by me. The brown cataract, if you were seeing, it was a right-handed surgeon. That was Dr. Lahane, sir. The pockets are very, very important. A lot of time has to be spent in making the tunnel because this ensures the safety. Otherwise, the iris will come out and it needs suturing. So again, this is entry, putting a bubble to stain the capsule and then doing the capsulorhexis under the dye. This is a very important step because there is no glow. I'll finish in a minute, sir, if it is okay. And then I'm using Utrata's forceps to do the rhexis. Forceps or needle, whatever is convenient, can be used to do the rhexis. And even an envelope technique would do in this case, which is a beauty. But in phacoemulsification, if you break the rhexis, you break the commitment to phaco because there will be complications. Now the rhexis is not completely done, but it can be finished even after extending so that there is more space to maneuver the forceps. Visco is put inside again and the rhexis is completed. I do not do hydro in a mature cataract because you do not know what is there behind. It's not necessary. And the nucleus will come out. By pressing the tunnel, even the epinucleus comes out. And it's very comfortable, very easy. And the cortex can be done and cleaned up. Here there is no AC maintainer, but it can still be done and the IOL can be put. So these are a few videos which show that how beautiful, how safe, how easy to learn this technique is. And like sir said, that we are doing majority of our patients by this technique. So it is a very, very good technique. It protects the endothelium. It can be done in all types of cataracts, in all type of cataracts with corneal opacities or pseudo-exfoliation. So there is no contraindication to do this technique. And poor endothelial count, Fuchs dystrophy, post-keratoplasty cataract, they recover faster with SICS and phaco because you do not know many years later when you see that the cornea may decompensate. At one time you may feel that you have done a beautiful phaco, but what about the corneal endothelium? So we are great propagators of this technique. I have done huge volumes and thousands of surgery by this technique, and it's a very simple and a very safe technique for the patient. Thank you so much.
Thank you very much, Dr.